In this lesson, we're going to discuss the different kinds of treatment for heroin addiction available internationally. At the end of this session, you're going to be able to describe the different drug addiction treatment therapies available internationally, describe the strengths and limitation of each of these therapies, and recommend therapy combinations based on individual client needs. So I just want to start out here by reminding you that drug addiction is a chronic relapsing medical disorder that is treatable. Not curable, but treatable. And through treatment that's tailored to the individual's needs, the patients are going to learn to control their addiction and live normal, productive lives. And there are medication treatments and behavioral treatments and combinations of the two. So, what are the targeted outcomes of medication treatment? There are several potential sites in the brain that are targeted by medications to help addicted individuals recover. And some medicines have more than one action, and they also work at more than one site in the brain. And others just have one action and work at one site. And some medicines are effective at treating several different drug addictions, while others are only effective for one type of drug addiction. And we'll talk about this in greater detail later. But there's a variety of possible outcomes that medical interventions might achieve. And medication can either block or maybe reduce drug cravings, or block and reduce the drug awards, like, for example, by blocking the high that somebody might get from heroin. Or maybe it prevents and or treats withdrawal symptoms, or restores normal brain functioning. Medication can also be used to treat any underlying psychiatric disorders. And medicines that have been developed for treating opiate addiction are obviously the most effective when we're talking about heroin treatment. So to understand how medical treatments target the brain, it's going to be important to understand how different drugs affect the brain and the body. So we're going to take a closer look at our brain over the next couple of slides. So the brain consists of several regions, and each one is responsible for specific activities that are vital for living, like movement, judgment, sensation, vision, reward, memory, pain, and also coordination. And drugs affects the brain chemistry, and hence it's going to change the way that the brain functions. The medicines for treating addiction are going to work on brain cells that are particularly vulnerable to addiction and its consequences. So the sites where these brain cells reside include the areas responsible for reward and judgment. So now let's talk about the different kinds of medical treatment for heroin addiction in detail. There are 3 medicines that are most commonly used to treat people that are addicted to heroin, and that's going to be methadone, buprenorphine, and naltrexone. And we're looking at methadone, Suboxone, and those are the 2, the buprenorphine and the naltrexone. So these medications have proven effectiveness, but factors like dosage and relapse potential and other side effects are going to continue to be researched over time. So opioid substitution treatment, or OST, works at the same site in the brain as heroin. This is the mu opioid receptor. But these medicines are safer and they're going to work for a longer duration than heroin. And treatment with these medicines is typically going to take between 1 to 3 years, but some may need it indefinitely. And they can use it to detox from heroin. So these medicines, they're going to work by alleviating the withdrawal symptoms and reducing or eliminating cravings to use heroin, but also by blocking the effects of heroin use by increasing the tolerance to opioids. Ultimate goal of OST is to assist people who are dependent on opioid drugs to reduce their risk of behaviors and also to improve their health. So OST is one of the most successful methods of reducing risks associated with opioid addiction. And the World Health Organization has a list of essential medicines that all nations are recommended to have to provide the basic level of services so that they can serve the health of the population. And both methadone and buprenorphine are listed by the World Health Organization as essential medicines. So, how does an agonist like methadone work in the brain? Well, agonists are chemicals that bind to a specific receptor site to elicit a response. So, methadone is an agonist that, like heroin, is going to bind to the opiate receptors. And unlike heroin, however, methadone does not produce that same level of euphoria or the same level of impairment to coordination and movement. So, look at the diagram here, and we can see a visual representation of methadone binding to an opiate receptor in the place of heroin. So methadone is recognized as the gold standard treatment for managing opioid addiction, and it's been found to be effective for the public health and risk reduction measures. So its use is usually restricted to specific medical conditions like treating opioid addiction and the management of chronic pain. But methadone is highly effective when you take it orally. And when you take it daily, like during maintenance for opioid addiction, its effect persists and the duration of its effect is extended beyond 24 hours. And although it is a potent analgesic for chronic pain, that analgesic effect of methadone is going to last for 24 hours. And if you're using it for pain control, the dose needs to be given every 4 to 6 hours. So methadone is it is detectable in plasma 30 minutes following ingestion, and it has a peak concentration after about 4 hours. It has a single dose half-life of 15 to 22 hours. That's a high variability there. And it has a maintenance dosing half-life of 22 hours and suppression of withdrawal for 24 to 36 hours. It has a stability that varies with metabolic rate, which varies according to genetic makeup or environmental or disease factors like pregnancy or HIV medications or tuberculosis medications. That's going to increase the methadone metabolism. And then the oral form only marginally is less potent than the injection form. So, what is methadone? So, methadone is a safe and effective medication for opiate addiction, and it's administered by mouth in regular fixed doses. And methadone has far more gradual onset of action than heroin does. And as a result of that, the patients are stabilized on these medications and they don't experience any rush or euphoria. And in addition to that, the methadone wears off much more slowly than the heroin does, so there's no sudden withdrawal. And the brain and the body are not exposed to that marked fluctuation that we see with heroin use. So maintenance treatment with methadone is going to markedly reduce the cravings or the desire for the heroin. And if an individual is maintained on adequate and regular doses of methadone, like once a day, and they try to take the heroin, the euphoric effects of the heroin are going to be significantly blocked. So patients on maintenance treatment don't suffer the medical abnormalities and the behavioral destabilization that those rapid fluctuations in drug levels cause for the heroin addicts. So this treatment is referred to as agonist treatment. An agonist is a substance that initiates a physiological response when it combines with a receptor. Methadone maintenance therapy, or MMT, is not simply just a substitution for opiate addiction, but it involves the use of a safe medicine that's provided in a safe treatment environment. So that's going to include an assessment of needs, and it's linked to a tailored response. Methadone doesn't produce that same euphoria or impairment that heroin produces. And the use of heroin and other drugs is closely monitored, and adjustments are made as needed in these treatment programs. So MMT is also going to involve drug counseling, assessment of health and social or legal or financial or vocational statuses, and linkage to other services. And MMT has been shown to have higher treatment acceptance and retention with no serious long-term adverse health effects. So clients in MMT are going to stay in treatment longer than all other forms of treatment. And the evidence suggests that methadone maintenance leads to marked reductions in illicit drug use, marked reductions in criminal activity, dramatic reductions in mortality rates and incidences of HIV infections, and also a marked improvement in health and psychological well-being. And among the HIV positive IDU patients, methadone maintenance is associated with more consistent use of the antiretrovirals and fewer hospitalizations. In one multi-site observational study, it was found that among these patients who were maintained on less than 35 milligrams a day of methadone while on treatment, 35% continued to use heroin. However, only 5% of those with a daily dose of greater than 60 milligrams of methadone continued to use heroin. So these data suggest that the higher dosage of 60 milligrams is more effective at achieving results. And other random assignment double-blind clinical trials have found that there is a dose-dependent relationship between methadone treatment and illicit drug use. So they found that the higher dosages correlated with higher retention in the treatment program, and it decreased the rates of illicit drug use. Especially a dose of 80 to 100 milligrams is superior to the 50 to 65 milligrams, and that's going to be superior to the 20 milligrams, which is superior to the placebo of no milligrams, obviously. So the best dose for an individual needs to be determined by the clinician, but the clinician's going to do a thorough individual assessment, and they're going to determine whether that client demonstrates any persistent withdrawal symptoms or persistent cravings or blocking of the effects of heroin while on the methadone. So the optimal duration of treatment is still being explored, but it is possible to say that methadone maintenance treatment is typically measured in years rather than months. A study in 2000 by Sees et al. Compared MMT, including standard counseling, to a 180-day methadone tapering program called Methadone to Abstinence, which was shortened to MTA. And they also included counseling and support services. And so the study found that MMT with standard counseling was superior to the 180-day MTA. And it also found that those in the MMT group had greater treatment retention and a reduction in heroin use and criminal activity. And the days per month of heroin use decreased from 30 to 5 for both groups during the first 180 days, but then increased to 15 days per month for the 180-day MTA group, while still remaining at 5 days per month for the MMT. So we can see the MMT is superior. And of course, methadone is the most widely used medication for heroin addiction treatment, but there are some key issues like the length of treatment and the range program services that are still being researched. And, like some of the other medications, methadone has misuse potential. If it's diverted or it's used in a way that's not intended to be used, and that's going to require it to be dispensed under direct observation in a highly structured program. And methadone doesn't really cost very much, about $50 to $100 annually. But staff dispensing costs can be high. So dispensing costs are going to be lower in countries where labor costs are lower. There's a lot of advantages to undergoing OST, like improving your health and your social, financial, legal, and vocational circumstances. It's going to suppress the withdrawal. There's no cutting agents required. It's an oral administration. You get a once daily dose. You get counseling and support that are going to help to maintain those lifestyle changes. It's legal and affordable. There's not that many long-term side effects. And there's a slow reduction in withdrawal from treatment that can be negotiated with minimal discomfort. So there's a few long-term adverse health effects from the use of methadone. That's going to be weight gain that's possibly influenced by fluid retention and dietary changes. Um, there has been a note of reduced production of saliva, which may contribute to dental problems. There's going to be endocrine changes that could result in impotence, low libido, or a disrupted menstrual cycle, and some possible harm in presence of underlying diseases like kidney or liver problems. And some of those effects disappear when the dose is adjusted, but the overdose risk in methadone is higher during the induction phase, while tolerance to opioids is still low and the dose has not been stabilized. So there is a risk if the client is taking other central nervous system depressants like benzodiazepines or alcohol in large quantities. And death due to overdose is caused by respiratory depression based on its effects of the brain. So daily attendance at a methadone treatment setting involves a substantial amount of time, and this can be a significant problem for people, particularly when the person is attempting to regain employment. And then additionally, some drug users complain of protracted withdrawal symptoms following the cessation of the maintenance program. And so these symptoms can continue for weeks or months. And a lot of drug users find that very distressing. So here we see a direct comparison between methadone and heroin, and it's going to show several advantages in treating a client with methadone. And in the chat box below this video, I'd like for you to kind of discuss what do you think may be some of the other health benefits of using methadone? Now, moving into buprenorphine. Buprenorphine is delivered in the form of sublingual tablets under the tongue. And buprenorphine is a partial opioid agonist, which means that although buprenorphine can produce typical opioid effects, its maximum effect is going to be less than that of heroin or methadone. So during the induction phase, buprenorphine is safer in terms of overdose risk than a full opioid agonist like methadone because it has a limited effect on the person's respiration. The maximum effects of buprenorphine appear to happen in the 16 to 32 milligram dose range. The higher doses are unlikely to produce any additional effect, but it will increase the duration of action and may only need dosing on alternate days. So it's easier to stop buprenorphine than methadone. And because of its opioid agonist effects, buprenorphine can be misused, particularly by individuals who are not physically addicted to opioids. So naloxone is added in combination with buprenorphine to decrease the likelihood of diversion and misuse. So sublingual buprenorphine has good bioavailability, while the sublingual naloxone has poor bioavailability. And what I mean by bioavailability is that's the amount of the drug that reaches the site of physiological activity after it's been administered. So when the buprenorphine naloxone tablet is taken as prescribed, the buprenorphine opioid agonist is going to affect, the effects are going to predominate. And the naloxone does not precipitate the opioid withdrawal in the opioid addicted user. But if it's injected by somebody like a dependent opioid user, the naloxone has a good bioavailability and it can precipitate an opioid withdrawal. So one disadvantage of the buprenorphine is its really high cost. So with buprenorphine, there's strong attachments to the opiate receptors in the body. And like I said, the average dose is between 12 to 16 milligrams. And so once the person is stabilized on the medication, it has a 48 to 56 hour half-life. So some individuals only need 2 to 4 dosages per week. And it's relatively easier to stop than the methadone. So it may be a little bit more expensive, but you don't have to take it as often. So let's talk about how a partial agonist, which is buprenorphine, works on the brain. So buprenorphine binds to the specific opiate receptors to elicit a response in the same way that heroin and methadone do. And the agonist effects of buprenorphine increase linearly with increasing doses of the drug until they reach this plateau. And then they no longer continue to increase with further increases in the dose. This is what we call the ceiling effect. And that's going to prevent the buprenorphine from producing the same level of euphoria that's produced by heroin. And it also means that it has less effect on respiration. So there's a lower risk of overdose during that induction phase. So the buprenorphine is going to carry a lower risk of misuse and addiction and the side effects as compared to the full opioid agonists like methadone. In fact, because it has such a high receptor affinity in the high doses and under certain circumstances, buprenorphine can replace any full opioid agonist from the receptor and block their effects. So in doing that, it can precipitate withdrawal symptoms if administered to an opioid-addicted individual while a full agonist is in the bloodstream. So naltrexone is an antagonist, and it's taken orally and daily for a sustained period of time. So people who take this need to be medically detoxified and opiate-free for a couple of days before naltrexone can be taken. And when it's used this way, all the effects of self-administered opiates, including the euphoria, are completely blocked. And this treatment is referred to as an opioid antagonist treatment. So naltrexone is associated with significant risk of overdose risk if not carefully supervised. And naltrexone is not widely used compared to buprenorphine or methadone. So antagonists are chemicals that are going to bind to a receptor site and block it, producing no response. And it's going to prevent other chemicals like drugs from binding or attaching to that receptor. So naltrexone is the antagonist that's going to bind to the opiate receptor and block the heroin from binding to it. So you can see that in this picture, how buprenorphine works, or methadone, how that works, or naltrexone. It's going to completely block it from allowing the heroin to continue to give that euphoric effect by binding to that particular site. And there are significant differences between agonist and antagonist treatments. In addition, there are significant differences in patient acceptability and retention. Opiate agonist treatments are much more likely to attract and retain patients in treatment than antagonist treatments. So let's review some of the key issues in considering the range of medical treatment options. The agonist maintenance, which is the methadone or the buprenorphine, substantially reduce the heroin use and the adverse health and legal, financial, vocational, and social consequences of heroin addiction. Problems with treatment adherence are going to limit the effectiveness of the naltrexone. And the combined treatment, which is a combination of medication and counseling, is going to be the most effective means of achieving the positive treatment outcomes that we're looking for. So we've talked a lot about the kinds of medication treatment options for drug addiction. So let's talk about behavioral treatment options. The primary objective of behavioral drug treatment is to help drug addicts learn mechanisms to stop using drugs and cope without them. And for the addicted drug user, drugs are highly rewarding and essential elements of life. So change requires recognition that the addictive behaviors are causing problems, and the benefits of stopping are going to outweigh the benefits of the use. And also recognizing that sustained abstinence, enjoying life while being abstinent, is realistic and achievable. And despite the previous failures, that our clients can succeed at stopping and staying off drugs. So in this part of the lesson, we're going to learn how to assist clients to change their behaviors and to provide them with strategies to reduce and eventually abstain from their drug use if they wish to do so. So there's numerous effective behavioral drug treatment approaches, but in this lesson we're going to discuss psychosocial counseling, cognitive behavioral treatment, and 12-step recovery programs. So psychosocial treatment encompasses this wide range of non-pharmacological approaches that are commonly used to treat addictive disorders. And many of these approaches are derived from the social learning theory. And they share the basic tenet that while biological and genetic factors are going to play a significant role, problematic drug use behaviors are learned in a social environment and they can be replaced by new learned behaviors. So psychosocial counseling is a really important tool in drug treatment because it's going to help motivate our clients to stop using drugs. And it's going to target the behavioral and social and the psychological triggers that contribute to continued drug use. And specifically, it improves interpersonal functioning. It's going to teach new skills to deal with family problems and pressure from friends who use drugs. And it's going to provide a venue for training relapse prevention techniques. And the most widely used psychosocial approaches that have received consistent empirical support are brief interventions, motivational approaches, and some various forms of cognitive behavioral therapy, which include training on some coping skills, relapse prevention, and behavioral couples therapy. And we know that counseling encourages patients to make lifestyle changes by developing some alternative reward activities and increasing involvement in drug-free social or vocational and family activities. And it's going to address problems resulting from years of addiction, like social, legal, work, health, psychological, and also family problems. And it's going to foster an adherence to treatment regimens. So, for example, counseling is going to increase treatment retention and adherence to pharmacotherapy, or taking the medications with the treatment. And psychosocial interventions can be used as a standalone treatment in conjunction with the pharmacotherapies. So the psychosocial interventions are used to elicit the person's interest or a commitment to change. But they're also used to teach them the skills to maintain that change. So the cognitive behavioral interventions comprise this wide range of approaches that are just broadly based on learning principles and the idea that behavior is influenced by the cognitive process. So how we're thinking is how we're behaving. And most treatment approaches that are supported by research evidence are cognitive behavioral in orientation. And the most prominent of these approaches are training on coping skills and relapse prevention strategies. And cognitive behavioral therapy is based on some pretty specific skills and technique sessions, like assessing high-risk situations, coping with cravings and urges to use, managing our thoughts about drugs, problem solving and decision making, drug refusal skills, and also planning for emergencies. So relapse is common in drug addiction treatment. As many as 60% of treated clients relapse within the first 12 months. So the evidence shows that specific situations and mood states are associated with relapse. So factors like negative emotional states, interpersonal conflict, and also social pressure are associated with relapse. And I'll throw in pain in there as well. Pain is another factor that's associated with relapse. So relapse prevention is not as much a specific intervention as it is a set of strategies that are aiming to kind of help the client achieve some relative gains in treatment. CBT, or cognitive behavioral therapy, is going to use a couple of strategies. It's establishing a positive and collaborative relationship with the client and positively reinforcing behavior change. And we're going to provide any corrective feedback when necessary and provide explicit structure and expectations for treatment and daily activities like scheduling of time, self-help meetings, exercise, work, etc. And we're going to utilize role playing and visual imagery and thought stopping. And thought stopping is a way of blocking thoughts that may be harmful and lead to harmful behaviors. But we're also going to teach skills to change the person's environment or their behaviors. And moving on to the 12-step recovery programs, like Narcotics Anonymous and Alcoholics Anonymous, or we could say NA or AA, these are based on peer-led mutual support groups. They're meetings and other related activities. So these group members are going to share the principles that addiction is a disease with physical, spiritual, and emotional components to it, and that there are 12 steps to gaining recovery from that. So the members come to meetings and they use their telephone contacts as an alternative to their drug use. And the users are helped to remember not to use through slogans and helpful reminders. So this process is going to involve admitting that one cannot control their addiction or their compulsion to use, and recognizing that a greater power is out there that can give strength, and examining some of the past errors with the help of a sponsor or an experienced member, and making amends for those errors. And then they're going to learn to live a new life with a new code of behavior. And then lastly, they're going to help others that suffer from the same addictions or compulsions. And these recovery programs begin with clients admitting that they have a drug problem and that they cannot help themselves. And the program is encouraging participants to surrender and is often going to include a spiritual component. So the 12-step program establishes a reference group of people with similar problems, which provides social acceptance for addicted individuals and a sense of community with other people. So during the therapy, other group members are going to provide examples of how to deal with their drug problems or their alcohol problems. And the program provides a very strong support and encouragement for its members to become and also to remain abstinent from drugs, because the only requirement for membership is a desire to stop using. They don't have to have stopped using yet, like some drug treatment programs. They just have to want to quit. So if we leave it untreated, drug addiction is going to lead to higher morbidity and higher mortality. And comprehensive treatment is going to reduce that morbidity and mortality, and it's going to improve the health and the vocational and the social, the financial and the family and legal functioning for that client. The ultimate goal of drug addiction treatment or alcohol treatment is to enable the client to reduce their use and achieve lasting abstinence if they're willing. The immediate goal of drug treatment or alcohol treatment is to reduce the drug use, improve the patient's ability to function, and minimize the health and social complications of their use. And drug treatment falls into one of three main categories: medication treatment, behavioral treatment, and self-help. The three drugs that we discussed most commonly used to treat individuals addicted to opiates are methadone, buprenorphine, and naltrexone. And among HIV-positive patients, substitution treatment is associated with more consistent use of their antiretrovirals and fewer hospitalizations. And the primary objective of behavioral drug treatment is to help drug users learn mechanisms to reduce and eventually stop drugs and cope without them. If you have any questions or comments, please feel free to put them in the chat box below this video in the lesson.